What's up, clinical family? Hey, it's JJ the RT here. Just wanted to come to you guys and do a follow-up, a little part two to the part one that I did with arterial blood gases. This time, this go around, what we're going to do is we're going to talk about kind of the common causes, treatment plans, things of that nature. So, what are we looking for when we have a patient who is in a metabolic acidosis? When they're in metabolic alkalosis, a respiratory acidosis, or a respiratory alkalosis. So, what does the patient present like, and what are we going to do? Um, what are we going to do to treat that patient? So, those are the things we're going to talk about with this course. I still want to do one more where I talk about, at least one more, where I talk about how to interpret arterial blood gases. Very simple interpretation. Now, again, when we talk about arterial blood gases and we talk about interpretations, we have to understand that there's a relationship. And some relationships are a whole lot more easy and simple than others. When you start to get into more complex relationships, those tend to be a little bit more trying and a little bit more challenging. But we're just going to talk about simple disorders right now. We'll get into later more of the complex disorders. But first, I wanted to talk about metabolic acidosis. So, metabolic acidosis, what we're looking at here is a low pH and a low bicarb. So, a pH that's less than 7.40 and a bicarb that's less than 24. So, anything, I don't want to say anything. If you just generically speaking, if we look at those two things, and that is kind of the causation of the low pH, the bicarb being low, then we typically have a metabolic acidosis. And the things that we're looking for there, um, the common clinical signs that we look at there are diarrhea, organic acidosis, meaning lactic acidosis or ketoacidosis, toxic ingestions or ingestion of toxic chemicals, and renal impairment. So I have those kind of listed here in a PowerPoint form. Again, that's diarrhea. Again, that's diarrhea, organic acidosis, toxic ingestion, and renal impairment. So those are the things that are causing a metabolic acidosis. Those are the kind of big hitters there. When we get into treatment, we have to typically treat the underlying cause. We have to figure out what is causing that diarrhea, what is causing that discomfort in the belly, whether it's a bacteria or um, anything else that's causing that diarrhea. We have to figure that out. If somebody's in DKA or lactic acidosis, then we have to fix their sugars before we can go anywhere else. So, um, again, fix the underlying cause before we can move forward. And the treatment with that sometimes comes bicarb replacement. Now, the literature is truly split on this. What does that mean? What that means is there are some studies that show the benefit of using bicarb, giving amps of bicarb to increase that uh, HCO3, that bicarb level, in order to bring that pH up. Then there's also studies that say don't do that because you're not fixing the underlying cause. You still have to treat what's going on with that patient. The bicarb that you give, that replacement, is only a buffer for the time being. Now, rule of thumb for me, and what I would typically suggest is I would look at the pH. If my pH is less than 7.20, then I would typically suggest to give a bicarb. I'm still a little bit hesitant with that because ultimately your patient is going to metabolize that bicarb, and one of the byproducts of that is CO2. So it increases your CO2 levels, which if you increase your CO2, drops your pH. So you're kind of at a catch-22 there, but if you are at a pH that's less than 7.20, your patient is at risk for cardiac arrhythmias. So you really want to, you know, look at that and weigh the differences and, do what's best for your patient in that situation. So again, if it's less than 7.20, I typically do suggest to use bicarb as a replacement. Um, oftentimes I've also suggested to help offload that pH or change, move that pH in the proper direction. If that patient's on the ventilator, I'll often do that with the respiratory rate as well. So if I have a patient that's on a respiratory rate of, you know, 14 to 16, 18, sometimes I will blow off additional CO2. I will increase that respiratory rate to blow off CO2 so that I get a higher pH. So just kind of depends on what that is going on with that patient. Again, just because I increase the respiratory rate, it does not kind of get us out of the weeds with fixing the underlying cause. So that's number one, is to treat and fix that underlying cause. Number two, either give bicarb replacement or make adjustments on your ventilator so that you can help offload that metabolic acidosis by putting that patient in a respiratory alkalosis. When we look at metabolic alkalosis, so now I have an increased pH and an increased bicarb. So those two are again directly related. So when I have those two things happening, typically, and again in simple disorders, if I have that bicarb elevated, the pH is going to be elevated as well. Those two work directly together. Typically, the common causes are one of four. You're going to have volume depletion, chloride depletion, hypokalemia, or aldosterone excess. So again, I have this set up in a nice little slide there. Hypovolemia or volume depletion, chloride depletion, hypokalemia, or aldosterone excess. And the mnemonic that I like to remember is havoc. So if um, typically if I have metabolic alkalosis, that patient's electrolytes are in havoc. So again, that's kind of a mnemonic for hypokalemia. H, hypokalemia. A is aldosterone excess. VO is volume depletion, and then C is chloride depletion. So I remember havoc, the electrolytes are all over the place, typically depleted, and then aldosterone excess. And treatment for that, 9 times out of 10 is going to be um, giving a bolus. When we give a bolus, we have sodium chloride in that, NaCl, and that will help with your volume depletion. And then with giving the sodium chloride, you give chloride in that, right? So that will increase your chloride depletion. If that patient is hypokalemic, then you will give some potassium. You're going to give that slow as a drip over a period of time. Never, ever, ever are we going to push that. And then lastly, as you increase hydration, the aldosterone excess, which is a protein that shows up during dehydration, that protein will start to go away as you rehydrate that patient. So 9 times out of 10, if you have a metabolic alkalosis, you're going to hydrate that patient with NaCl or potassium drip over a period of time. So that's the treatment plan for metabolic alkalosis. Respiratory acidosis. So with respiratory acidosis, you can have any pulmonary disease. It doesn't matter which one. You can name any of them, and that can cause a respiratory acidosis. Again, a respiratory acidosis, my CO2 is climbing and my pH is dropping. My ventilatory status, my lungs are not working as effectively as they should in order to blow off the CO2 that we need to maintain that normal pH. Remember that teeter-totter that tilted one way or another? We want it to stay on that even kill. If my CO2 starts to go up, then my pH will drop. So if that CO2 goes above 40 and my pH drops below 7.40, I'm in that respiratory acidosis. Again, simple disorders. We're not talking about COPD patients. We're going just straight simple disorders right now. Sometimes neuromuscular deficits can cause a respiratory acidosis. So you've got those two things um, that can cause that respiratory acidosis. And again, increased CO2 production, meaning an increase in of metabolism, where where my cells are working harder and going through that Krebs cycle more often and off-putting carbon dioxide, that can cause an increase in CO2 production. Um, if I have a pulmonary pathology going on at the same time, then I will not be able to effectively get rid of or eliminate that CO2, so that can cause that respiratory acidosis. We've got the neuromuscular disorders. So, depending on where your brain is affected, it can slow your respiratory rate down or knock it out completely and cause that CO2 to go up, which drops your pH, making you acidotic, any pulmonary disease, and lastly, an increase in CO2 production. This is going to be like your COPD patient, okay? I typically think of my COPD patients as somebody that just woke up from a deep sleep. You know, when you have that really good dream going on and your partner wakes you up, right? And you wake up and you're kind of red-eyed and you might be a little combative, you might be a little frustrated, right? You think about a patient who struggles to breathe, right? If they're struggling to breathe, they're gonna be a little irritated. They're gonna be a little frustrated. They're going to have that red eye. They're going to look tired. One of the other kind of symptoms of having an increased CO2, an elevated CO2, is vasodilation as well. So um, it's nice to understand that that relationship with increased CO2 causes vasodilation as well. Um, and just know that that patient may be a little delirious, maybe a little combative, just because they're having a hard time breathing. Now, if that CO2 gets elevated to a point to where they become unresponsive, that can happen too. So just be mindful that, you're going to be a little agitated at first, and if that CO2 continues to climb, that can knock that patient out and they'll be comatose as well. Um, Treatment for that is reducing the ventilatory load. What do I mean by that? If it's tough for them to breathe, help them out. If you're working out at the gym and you're trying to do 10 push-ups and you can't get all 10 of them, but you have somebody to kind of grab you by the shirt and help you up, they're helping with that that physical load of pushing yourself off of the ground. So if you have a device like a BiPAP or a ventilator, sometimes a high flow nasal cannula to help offload the ventilatory effort of that patient, that can help in these cases. You want to increase the muscular strength of the diaphragm. If I have somebody who's got a weak diaphragm that doesn't have a cough, a strong productive cough, or somebody that's been on the ventilator for several days, that diaphragm gets used to the ventilator doing the work. So sometimes you have to exercise that back up, get that strengthened so that um, we can help blow off that CO2. And again, you can put that patient on the ventilator, um, or have some sort of ventilation, either non-invasive or invasive. So again, looking at respiratory acidosis with the treatment, we're going to reduce the ventilatory load, we're going to increase muscular strength, or use ventilation of some sort, being invasive or non-invasive. Respiratory alkalosis. Okay, like this patient's going to be hyperventilating. They're going to be breathing really fast, blowing off CO2 to increase that pH. The number one cause of an increased respiratory rate, the number one cause of an increased respiratory rate is hypoxemia. So if I am not oxygenating my tissues, if there's not enough oxygen in my blood, I'm going to breathe faster. Okay, we're getting into the central chemoreceptors and the peripheral chemoreceptors right here. Um, won't dive too far into that. Albuterol is one of those medications that we give a lot of times for pulmonary diseases. Now, there's really only a couple of indications for albuterol, and that's reactive airway disease. That is the indication for giving albuterol. If they don't have reactive airway disease, then what we're doing is moot. Um, but albuterol is a respiratory stimulant, and if you give somebody large doses of albuterol, you can cause them to be overstimulated, making them hyperventilate. Um, Chemical or physical environmental factors. So you go to a haunted house, right? You go to a haunted house and you got Jason running after you and scaring you. You're gonna hyperventilate. You get into a kind of a um, a psychotic state where you are hyperventilating and you just don't really know what's going on. You get into that high anxiety state, and you can get into that hyperventilating state, and that can cause a respiratory alkalosis. And we talked about the last one, psychological factors. So again, hypoxemia or hypoxia, direct stimulation of the pulmonary system with medications and chemical, physical factors, and then psychological factors. So those are the four that common causes of respiratory alkalosis. Um, there are times that when we have a patient who's on a mechanical ventilator, we tend to put them in a respiratory alkalosis. Like I said, with metabolic acidosis, I've put my patient in a respiratory alkalosis to help try and compensate for that pH. But other times that we put patients in a respiratory alkalosis purposefully is when they have a head bleed. What that does is when we have that increase in CO2, it causes vasodilation. And then whenever you have that decrease of CO2, it causes vasoconstriction. So what that will do is that will help eliminate, or that will help slow any kind of bleeding or swelling that's going on in the brain. So there's times that we put these patients in a respiratory alkalosis so that we cause that vasoconstriction so that we can help intracranial bleeds or ICBs. And again, with respiratory alkalosis, we have to treat the underlying condition. If they're hypoxemic or they're hypoxic, then we give them some oxygen. If they have gotten too much respiratory stimulants, we need to cut back on that. Albuterol does not fix it all, so let's stop giving it for everything. Um, Physical or environmental factors causing somebody to hyperventilate, get out of the haunted house. And psychological factors, you just want to kind of remove them from that psychological state and get them the best help that they need for that situation. So I hope this helps. This was kind of a quick overview of what you would see and how you would treat metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. I hope this helped. And I've got some more videos coming. So look forward to seeing you guys in the future. Be sure you subscribe, you like, and leave comments. If you like what you saw here, hit that like button. If you like what you saw here, go ahead and hit that subscribe button too. And if there's anything that you want to see in the future or you have questions about, hit me in the comments.